All right, welcome to The Boost, conversations with people promoting mental health. And I am your host, Steve Turney, and I'm here with Tom Conti, who's the founder and CEO of Sweet Science Marketing. And I'm also here with Chris Hassan, the vice president of SUD services at UHS. Tom and Chris, how are you all?
Doing well, thank you.
Great. Thanks for asking.
Yeah, definitely. I'm excited because in just a couple weeks, you all will be on stage at the Mental Health Marketing Conference, educating folks with your expertise. We're going to share a little bit about that in advance today in the next 30, 40 minutes. So I'm looking forward to talking with you both. And the way we always do in these episodes, we're going to start with two questions that lead us down the path that we'll walk together, and that is the virtual hug and the shameless plug. So why don't each of you start with the virtual hug, which is just simply tell us somebody or something you're grateful for today.
Well, I'm grateful for Chris Hassan because he's been a valuable client and friend for a number of years, and gave me and us the opportunity to do some things. We think of our jobs as marketing, but it put us in a position to actually get out there and help some people in need. And for me personally, that was, I would have to say, one of the more gratifying things that had happened throughout a career that has now spanned almost 40 years. So just want to pass that on to you and to Chris.
Thanks, Tom. I'm grateful for you as well. The thing that I'm most grateful for in my life is my family, both my extended family and my immediate family, and the opportunity that they provide me to serve patients seeking recovery from SUD. Most of these patients have a mental health comorbidity. Mm-hmm. So we've come up with a treatment model in my career that's been proven and reimbursed for in healthcare that treats both comorbidity and the MAT, substance abuse issues that they suffer from. And in these situations, when we do that appropriately, most patients fail from an incomplete treatment. It's not the treatment. It's not that patients have failed. The treatment has failed the patients. And with the models that we have used over the last 10 years, and Tom and I partnered on how to get that out to patients and family members as well as referral sources, we actually were able to discharge patients. And one of the things I'm most proud about with that, when I partnered with one of the payers in the market, we analyzed our patients 12 months post-discharge, and these patients, by and large, had not relapsed and were 64% less expensive to the payers, which just encouraged our payer partners to bring more patients into care, recommend them come to us, and get the care that they deserve and get the treatment that they deserve. So I'm very, very grateful for these things. It gives my life meaning. My family's involved in the past as patients, and currently my children are both in the process of becoming credentialed and disciplined, one in the master's level counseling level, and the other is doing pre-med studies at the moment to become a psychiatrist. So it's not just a job for me, it's my life's work. So thank you for asking.
Yeah, absolutely. Family, a loved one, that's the number one answer by far I get from these questions. Although I also love Tom's answer as well. But yeah, and you're right. There's a lot of co-occurring comorbidity occurrences that are going on when we start to talk about SUD and MAT and behavioral health and mental health and what all that means. And obviously you're driving some more some very effective results, and you're looking at some quantitative ways to track those outcomes because as we move from fee to service, even in the biohealth side of things, toward more taking on risk and managed care and making sure we have an integrated kind of care solution for people who need it. The mental health side of things and the addiction side of things is going to have to really come along with that. And it sounds like as I expected, one of those people at the forefront of it. So it's a perfect transition into the shameless plug. So, Tom, I'll start with you. Why don't you tell the audience just the work you're doing, maybe how you got into it, whatever you think is relevant for the clinicians and executives and marketers out there who are listening. Tell them a little bit about Sweet Science.
Sure. So, Sweet Science, I founded it in 2016 after a career of working with, I guess, some of the largest holding company agencies, in the world on some of the best brands.
Hmm.
Um, and one of the great frustrations that I had as technology was advancing and as data was being put into the equation is that it was very difficult in organizations that were that large to really put those disciplines and new capabilities into play in a way that would really provide better uh, outcomes, more accountability into the campaigns. Because in organizations that are that large, there's a lot of silos. And for me, it was actually seeing the opportunity, understanding what clients wanted, and trying to build it from the ground up. So we started by building a really robust data backbone that enabled us to deliver more predictability and insights on the front end of campaign development, and then greater transparency and accountability on the back end of the campaign, so that we were not only improving outcomes over time, but we were able to optimize in real time to do it more quickly and more effectively. So that's what we built. Hence the name Sweet Science. The science part of the equation being the data and technology, the sweet side of the equation being all the creativity, messaging that's layered on top of it. And throughout my career, spent there was always a significant part of my portfolios that were that were related to the healthcare space,
Hmm.
and it is a cornerstone of Sweet Science. We're doing a lot in healthcare, from working with pharmaceutical companies to providers to insurance providers, nonprofits, and medical devices. I think we have a healthy dose of that in the agency, but recently we've really started to get involved in areas of mental health and addiction, which is how Chris and I met. And when you think about this data driven approach, as I mentioned in the beginning, I think that this takes it enables us to leverage our competencies and our disciplines to obviously create effective campaigns, but in these spaces it really is about changing lives. It's about, when we talk about outcomes, it's much more activation based, conversion based, that are getting people the help they need. And by delivering that, it has, the outcomes are not only important in terms of campaign metrics and success that clients are looking for. It's really impacting the lives of people that are being served by the clients that we work with. And I think for me that's been just a major step forward and an evolution of my own career, my own thinking about what we do um, in an industry that I don't know, it increasingly seems to be diluted in terms of the value of what it can actually contribute to society. So, to me, I would say that's the shameless plug for Sweet Science.
Beautiful. Yeah. Both industries, mental health and marketing have been, there's some fuzziness. There's some whiskey and guessing that used to go on quite a bit with the marketing side decades ago. And, this move toward a data driven approach. And there's still always space for the art and for the brand and the long game of how a brand can impact somebody over years or decades. But the ability to drive toward outcomes with the tools that we have available to us, worked well, you can have a huge impact on an organization. And I also agree, the people I've met at behavioral health and mental health companies, have this extra spark of knowledge that they're working on something, especially important and impactful, the paths that they've picked for themselves. It seems to almost more often than not, almost to no exception, be something that people are highly motivated about the work, in part because of the impact they can have on people's lives. This isn't marketing Coca-Cola. This is being there for somebody who needs help when they need it.
Exactly, and it's we use it in so many ways. We use the data in so many ways. We use the technology in so many ways. It's about greater insights to understand the segmentation. When you think about, when you're dealing in mental health or you're dealing in the addiction space, the drivers, that and the insights into the mindsets of the people that you're trying to connect with, that may happen at the at the what we'll call the patient level. Also, the loved ones and the influencers that are involved in their lives, that can actually help lead them to the right solutions. The segmentation and what that looks like, it's not a one size fits all solution. And the ability also to bring together multiple data sources to identify within any given geography where the greatest need exists by looking at specific data sets that can give us those clues, enables us to leverage the dollars that are available to really laser target with the messaging, to make sure that we're eliminating the waste and really putting the greatest weight against those communities where we can do the most good. And I think both of those things have really enabled us to not only do things in a different way, but I think show disproportionate effectiveness in the way we do it.
Hmm. That's awesome. Yeah, segmentation is something I think about a lot on the marketing side of things, but also when it comes to the social determinant side of things and demographics and different communities that may walk and talk a little differently in terms of how you can best connect with somebody and find that affinity, and that use that empathetic language and share the right stories, or share more relevant stories. I think marketers generally could do a much better job of segmenting, but it takes data analytics, and it takes some extra work, of course. But the output is it can be so rewarding. Chris, why don't you give us your shameless plug? Tell us about your background, what the work you're doing, and some of the impact you're having out there in the world.
All right, thanks. My background, I came from a family where alcohol and was a severe problem. I've been to as a kid, been to family days in the resi programs, and I've seen the impact that the disease can have, addiction can have on families and children and things like that. I I was brought into this industry kind of through the back door, and that I started off in healthcare in pharma, but I had an opportunity to work for a startup that was putting together a depot naltrexone formulation, which resonated highly for me. I got to meet some of the greatest minds, early minds in the field, whether it was Dr. Volpicelli at the University of Penn, who was key in the discovery for utilizing um, naltrexone in multiple SUD conditions, or getting trained by Dr. Tom Pate, who was one of the four founders of kind of the addiction MAT services in the country back in the 60s and 70s. And then, of course, one of my earliest mentors was Dr. David Smith. He's the founder of the Haight-Ashbury Free Clinic. He's the gentleman that founded the California Society of Addiction Medicine, which then changed into ASAM. And he was also the doctor who went to the American Medical Association and got addiction medicine recognized as a legitimate subspecialty. So, I've seen in the last 25 years, the industry's kind of gone through a big revolution, which is wonderful. Um, and there's a lot of changes in the marketing for that. So my career from there, I was one of the founders of the organization and the company that launched Suboxone. So I worked greatly closely with the federal government as we did that in a cooperative research agreement. and then crossed over into the uh, the treatment side because that's where I really wanted to get. Right, so I did a number of different things, including a kind of an early stage company looking at the impact of GABA dysregulation on SUD, and then got into the treatment side directly by doing a couple of turnarounds and focusing on OUD, opiate use disorder. And uh, the issues that I saw was what I kind of mentioned early days was that the treatment was all siloed and it was incomplete. And we refer patients out to go get a psych consult, but especially in Medicaid programs, something on the order of 30% of psychiatrists even accept Medicaid. So there's a significant shortage of psychiatrists and psychiatric nurse practitioners in this country. And then then the subset that would treat in a Medicaid population is drastically undersized.
Hmm.
So I came up with a treatment model where we would have it more comprehensive, where we would have all of the services become a medical home as well as a psychiatric services, all in the same clinic, all with the same EMR. So everybody, it takes a whole village to raise a child. Well, it takes a whole treatment team to help a patient, an SUD patient, in a recovery and stay there, right? So it's been great. I joined UHS after basically an early retirement because they have the scale nationally. They are the largest provider of BH, behavioral health services, in the country, but they had a gap in that they didn't have any true outpatient MAT programs per se. So it's been very valuable to me and very helpful to be able to have a company that's committed to patients like this, pushing for us to get into the market and to establish this type of a treatment model. The way I met Tom was before this. I was utilizing a small platform in Chicago to be able to build out. And the problem that I had, and this was originally, right, was the market at that time when you did marketing for SUD, it was all you go to the web pages and everybody had a sunrise and everybody had a lot of smiles and they had their dog with them or they were walking up a hill and everything was the same. I've talked to patients and family members that are homeless. I've talked to billionaires whose families had this kind of care issue, and they would tell me everybody says the same thing. I don't know how to pick, and my child still died. So there was clearly a messaging situation that was needed, and a whole different kind of approach to addressing the market. The other thing, when I first got into this market in behavioral health or in addiction specifically, I'd say it was more like a religious war because when you would go and start to talk to providers in my early phase of my career about different opportunities, they said, no, I got sober this way. It's the only way that works. And so their offering was exactly replicating their personal struggle, which adds value. They're bringing a lot of passion to the field. And that's like you referred to earlier, Steve. But, you know, many pass into the disease, many pass out of the disease. So what we've developed is we have an entire toolbox. We have every medication that's available by the FDA. We have all the treatments, whether that's residential, residential or a BH hospital, whether it's IOP, PHP for outpatient, and of course all of the materials for people that suffer from OUD and AUD in one clinic with a treatment team that involves physical health, counseling and behavioral health, psychiatry care. We do all sorts of different things in that way. And so the patient gets an entire treatment team, and that kind of cohesion provides a unity. It provides outcomes that are unsurpassed. And so the way Tom and I worked together, I had started a longitudinal process where I went out and I bought all commercial claims for all SUD patients, all OUD patients, let me be specific,
Hmm.
in the United States for 5 years. So what we had there was a database of 3.2 million patients, a subset of 1.6 billion claims paid. And then I went out and I got a gentleman who was an MD and a PhD who had taught medical informatics at Harvard Med and at MIT, and then went and moved to the West Coast and opened his own shop. And I allowed him to do all of the analytics and the analysis because I wanted to be credible that it didn't look like I did it. and I wanted it to be relevant. And he was an MD, so he would be able to interpret the claims in a manner that would have impact for families trying to make decisions and for payers who are trying to understand what they're contracting for.
Yep.
And the result was is that we were able to show payers a longitudinal view. And I had one payer tell me, we never looked at data longitudinally for our OUD patients. And I asked, why is that? And he kind of looked to his left and looked to his right and he says, because nothing works. And I have to tell you, the data kind of showed that because patients would get better and then immediately relapsing. And it would be like a roller coaster. And we know the more times a patient relapses, the more difficult they are to get them back into treatment because they begin to just think that this is their path. This is who I
Yeah.
am. This is what I deserve. Thinking that's not helpful, right? So so Tom was able to take this data and look at it as a marketer's mindset and be able to, come up with messaging and a way to present it to families, referral sources, that sort of thing that actually had dramatic impact. And with that data you had kind of mentioned earlier, I was able to go at risk, right? So I would do a value-based contract where I went at risk and it was very profitable for the organization. We got paid for what we delivered, the value we delivered, which is really, really important and quite fair, to be honest. And as a result, we were averaging on our patients a reimbursement rate for those patients about 4.5 times the national average. So it was very um, impactful to the business as well, which allowed us to then expand more and more, bring in more providers, bring in more treatment, bring in more patients, impact more lives. And
That's awesome.
so, yeah, that's kind of the net right there. So that's what we're doing now at UHS more and more. We're building through that. The opportunity to partner with a national platform and a player that big. My personal goal, my life goal that I'm working on right now is I want to get 250,000 patients into recovery, not into treatment. I want to get them into recovery and I want to discharge them. And the thing that was, like I said before, when the payers looked at these patients, when we discharged them, which never happens in an OTP where we're using methadone for fentanyl and Suboxone for everything else, they just don't, we say it's kind of like the Hotel California. You check in, but you never check out. And that's not the way we did it. We were able to get these patients whole and healthy and functioning. And when they looked at it, it was we normalized the cost of these patients to the plans, which that's not our outcome that we're seeking, but it is an outcome that is very useful. We're seeking to get patients whole, happy, productive, get their lives back, get their jobs back, get their families back, get their health back. And so it's a meaningful thing for us. So that's my shameless plug.
That's awesome. And, for anyone who doesn't know, experts in healthcare, typically talk in shorthand. And OUD is opioid use disorder, and OTP is opioid treatment program. But Chris, that's a wonderful shameless plug, and it sounds yeah, going at risk and driving outcomes across longitudinal analysis is was novel in some cases, and it maybe should be more of the standard. But I loved your point about many paths in, many paths toward recovery, and it's such a easy trap for us to fall into, to say, oh well, I had this experience that was positive, this must be the way for everyone. And yeah, I mean, certainly we'd love to see recovery and treatment for everyone who needs it, and we want to see 100% recovery rate, of course, and we want to see zero suicide rate, all these things. But it's just too complex. It's just there's just too much complexity and too many unknowns, and even what we don't know about how the mind is working, and how it correlates to the situations we're in and the relationships we have. But Tom, I wanted to circle back to you because Chris was talking about sort of this critical moment in time, or this critical step in the process where he sent the data to you to analyze from a marketer's mindset. Talk more about what does that mean? Like what were you doing? What kind of fresh approach or perspective did you bring to that process?
Well, I mean, having immersed ourselves in all of the data that he was generating. The first thing was, he started with this one practice, if you will, in Chicago. Um, we asked for focus, right? So let's really position this organization as the experts in opioid addiction treatment, and rather than being all things to everyone, the protocol that's been developed really is proving to be extremely effective and breakthrough against this one specific disease. And at that time is when we were seeing the hockey stick in what was going on in terms of in terms of opioid addiction, in terms of deaths from opioids, and the crisis that was really happening was really escalating at that time. So the first thing we did was, let's focus. This is going to be the mission of the organization. It's like we have one mission, and that is, really treat opioid addiction treatment, be a catalyst for solving the opioid crisis with this new treatment protocol. Second thing was, we're going to brand the protocol so that it becomes a mnemonic for everybody that is looking for help, be they someone suffering from the disease or a loved one that has watched, their the person that they care for go through treatment 4, 5, 6, 7 times and not achieve a lasting recovery. Well, there's a reason for that, and what Chris had developed and the team was bringing to the market, we had an opportunity to brand the method, and we did that. Um, the next thing was, uh, within that method, illuminating that there were three key elements to it, right? So, critical to it was that it was happening in an outpatient setting, along with the medication assisted treatment that was part of it. Because what we learned was, you have to get rid of all of the sort of the effects that keep people um, with the cravings and everything else, trying to find their next opioid dose, if you will. So
Yeah.
we wanted to make sure that we could communicate clearly that with this treatment method, the reason why MAT was being used was because it would really get rid of the cravings, get rid of some of the behavioral things that were happening and the effects that were preventing these patients from really focusing on true recovery, and then start to deliver the behavioral health and get them into a protocol that was driven in an outpatient setting. So we had one mission, which was the opioid crisis. We had this branded treatment that had three key components: the MAT, the behavioral health, and the IOP in the outpatient setting. And then Chris said it. It was documented that they were delivering 4x and even more, even greater, the lasting and sustainable recovery results as a result of this, of this treatment method. So that was giving everybody that had either gone into treatment and had failed, or folks that were really grappling with, I'm really ready, I think, now to get myself into treatment, the hope and the reason to believe that this was going to be the one that was going to work. Um, so that's how we built the campaign. I think the other key element is we attacked the disease and not the person suffering from the disease. We made opioid addiction really the one that was the problem, and not the person that was suffering from the disease, to sort of take that burden off of them. Right? It's like the disease became the enemy, the disease became the target, and we clearly were trying to open up these people that were suffering, uh, to basically approach treatment in a different way. That it was purely attainable, and not to paint them as a victim, but to let them know that this is something greater than you can handle yourself. And I think that worked very, very well. On the
Mm.
back end, the conversion environment was just as important because intake and how we were managing intake needed to be handled in a way that was going to get the conversion rates up so that we could get as many people into treatment as possible. One thing we knew, not only with this particular work that we were doing with Chris, but from previous our work in the category previously, was that it's a scenario where if it's somebody suffering, you're going to get one shot. If they happen to call, if they're in crisis, you've got that one moment. And if you don't get them then, the chances of them coming back are highly unlikely. The loved ones, on the other hand, it's a different type of conversion. You have to educate. You have to give them the confidence that this treatment is going to work, knowing that perhaps they have financially been burdened, emotionally been burdened with failed treatments in the past. Um,
Yeah.
that's where the data came into play as well, because we had these documented outcomes. Um, so all of that, both on the front end, in terms of attracting people into, into the centers, as well as making sure that we were disproportionately capturing and converting patients on the back end, really drove the success of the organization over time. And the more we did it, the more refined we became because of the data views that we had to optimize it. We were able to optimize quickly, which drove not only greater patient census but also greater campaign efficiency, meaning we were capturing more patients at less cost the longer that we were involved in this. And over 3 years, it drove significant expansion for the organization.
Mm. Tremendous. There's so much in there. I think it underscores the idea that um, I mean, yeah, this is going to be. I'm not going to be able to do this justice, but it is. It brings up a point like we don't talk about I am cancer. I have cancer. We don't talk about mental health maybe that same way, but there is the potential for people to get ostracized based on these behaviors, and I can't say like too much about it, but someone who I loved, someone in my circle of friends, I watched them get ostracized by sort of a religious spiritual community. Probably not ill intent. Everybody loved this person, but I just watched his mind change related to fentanyl or opioids. Which continues to just iterate and unfortunately, quote unquote, improve on the efficacy of that drug, and what they're doing with research and development to make it even stronger than it is right now, but to remove the chemical and bio reactions of addiction in many cases, uh, if not entirely across the board, with how things are impacting us as humans without us needing to carry the identity of this is who I am. Yeah, I think that's a wonderful point, and it just really underscores. It's kind of a simple idea of how critically important our words are, whether and to be able to use them for good, efficiently and effectively, whether it's somebody who is at that moment of crisis where they have the ability to be reached, or their circle of friends and loved ones who need the education, like you said. To be able to take a data driven approach to the marketing, and then speak a language that resonates with the reader, or the website visitor. That is such a critical component of getting the care into the hands of people who need it.
Well, it's the word that I was struggling for is, we were talking about how did we handle it. I think when we rolled it all up, it was really about trying to destigmatize the entire thing. And it was the stigmatization of it that would prevent people from picking up the phone or going to the website or asking a loved one for help. And I think the campaign, Chris had talked about sunsets, and whether I'm not going to name names, but regardless of who you were looking at when we were evaluating the competitive landscape, it was a sea of sameness. And ours took it from a very pragmatic approach that, again, focused on attacking the disease to destigmatize it for those that were suffering from it. And I really believe that was the power of the campaign.
That's powerful. Well, Chris and Tom, thank you both for being on the show. I do want to ask you one more question before we wrap up, which is, this is such a nuanced field, and you both know a lot about it. What's something you are either reading or listening to that you might recommend somebody pick up and tune into in terms of connecting with this industry a little bit more, or learning from some of the people out there who have been making some groundbreaking moves in this space? What interests you in that regard?
I'll let Chris take that one. Take that one first. He's probably well
Sure.
more read on it than I am. But
It's probably Chris. People need to call Chris.
yeah, exactly. Well, they do need to call Chris.
Yeah,
Um,
so there's a book called Silence of the Scream that I just got referred to, and it's talking about the war on drugs, and it talks a lot about um, how the messaging has changed, and how the industry has grown bigger and bigger, and drug use has spiraled out of control. So this is something that I am very interested in, um, to see how that works. I also would recommend, if you haven't seen the movie Dope Sick. It's a multi episode show. I know the physician who that movie is based around, partially a true story. It's been fictionalized around some of it, but it's the story of how prescription opiates got out of control. Great, it's a great kind of eye opener on that. Um, and so those are the two things
And
that
an
I.
interesting marketing angle there too, right?
Yeah, and the thing that I was most disappointed from, but not surprised, was at the end of the movie. At one point, he's in line talking to somebody, and then he steps up to the window, and it's a methadone clinic. You don't know that at the time. He swallows the methadone and walks right out. That ain't treatment, but that's the state of the industry in a lot of places. But I'm very happy to say it's shifting dramatically in our field. That people are bringing in more and more care, and that's all to the advantage of patients and families. So.
Um,
and I think for us, it's we tend to look at some of the people that have organizations or are published authors in the space of opioid addiction specifically, because we just have such a passion for trying to solve that problem. And Ryan Hampton has always been I think a tremendous voice for the community, and he has several books out there. Most recently, I guess he just has a new release on the America's failed war on drugs. I think it's called Toxic Politics, I believe. But he's a great one to find and read the publications and the articles that he's authored. It just gives you great insight as to what's going on with this disease, and why we are failing as a nation in trying to solve it.
yeah, he's at ryanhampton.org. Awesome resource there. Well, thank you both for being on the show. Lots to learn from you in this episode, and then in the weeks to come at the conference. I'm excited for a part two. I'm glad I got this download here, because this is going to be a rich conversation, and it's a really great community that is very open. So I think a lot of people will benefit from you all just being around and having conversations to move this all forward. But thanks so much.
Steve,
Thank
thank
you.
you.